ultrasound of the kidney, blood. Obviously, one can do a pretty simple blood test. So there's lots of new information out there. We're going to go to a word from our fantastic sponsor, and then we'll be back with new news about medical procedures being worthless in some cases. For new or recurrent cancers, Radiosurgery New York specializes in new, non-invasive cancer treatment choices. First in America, first in New York, first for you. Body radiosurgery cancer treatment. Decades of experience with primary and metastatic, large or small cancers. Cancer treatment from head to toe. Acoustic neuroma to prostate cancer. We hit the cancer with no cutting, no bleeding. Hi, I'm Dr. Gil Lederman. We're the cancer treatment radiosurgery pioneers, with possibly a second cancer treatment chance for you, even if chemo, radiation, or surgery didn't work. Our cancer treatment is outpatient with most insurances, Medicare, Medicaid accepted. Minutes could change your life. Call me at 212-CHOICES, 212-CHOICES to hit the cancer. Ask us about hyperthermia, too. We're super convenient, 38th and Broadway in Manhattan. Call 212-CHOICES, 212-CHOICES to hit the cancer.
News Talk Radio 710
WOR.
For prostate cancer treatment, results and quality of life matter. Hi, I'm Dr. Gil Lederman from Radiosurgery New York. Our enviable record includes treating thousands with prostate cancer. Critical to every man with prostate cancer and their loved ones is quality of life, urinary and sexual, and great treatment data while avoiding surgery. Treatment here is outpatient, with most insurances, Medicare, Medicaid accepted. First in America with radiosurgery for cancers from head to toe, we have the expertise to hit the cancer. Our fresh second opinion could change your life. For prostate cancer treatment, call 212-CHOICES, 212-CHOICES. Radiosurgery New York. Super conveniently located in Manhattan at 38th and Broadway, we hit the prostate cancer. Call 212-CHOICES, 212-CHOICES to hit the prostate cancer.
Welcome back to the Radiosurgery Hour. This is Rob Redstone here with Dr. Gil Lederman at the WOR studios in the heart of New York City. We're just a few steps from the Radiosurgery New York Cancer Treatment Center on Broadway and 38th Street. Dr. Lederman, the leading cancer expert, treats prostate cancer non-invasively. He was the first in New York with fractionated brain radiosurgery, and he's the first in America and in the Western Hemisphere with body radiosurgery. You can also call Dr. Lederman at 212-CHOICES for a free informative booklet and DVD. Hey, Dr. Lederman, we're back.
Hi, welcome back. We're here with Ariel, who's my co-host. Good evening.
Hello.
So there's a new study out from the Journal of the Mayo Clinic Proceedings, and it talks about medical procedures that may be worthless. Can you believe that?
That's tough to believe. You always think doctors want to do the best.
Well, doctors do want to do the best, but sometimes there's medical procedures that are worthless or even worse than worthless. So
they cause harm?
They can cause harm. Did you know how George Washington died, by the way?
I think it was a doctor doing some blood thing.
Exactly. Well, you're about the only person in America that knows the answer to that question. If any of our viewers or listeners knew that, call in and tell us how you found out about it. You are right, Ariel. He had epiglottitis. George Washington had epiglottitis. In those days, so this is about 225 years ago, medical practitioners and barber surgeons believed in humors, that humors had to be balanced in the body. There were black humors and blood humors and phlegm humors, and there was a balance between them. And he had this epiglottitis, which in this day, how would you treat epiglottitis today?
Well, you have vaccines, I believe.
Yeah.
And they can give it to kids.
And maybe antibiotics. There's probably different things to treat it, but we wouldn't do bloodletting. So they removed about 5 units of blood from George Washington.
That sounds like a lot.
And he died from that. So what's iatrogenic death?
Death that someone causes.
Yeah, who is someone?
Can be a healthcare provider, I'm guessing.
Yeah, it's in the hospital or one of us doctors. So iatrogenic means you go in and something bad happens, and death means the death was probably related to doctors. So George Washington died from his practitioner who was trying to balance the humors in his body. So from that, we know in our country that there can be medical procedures that aren't good, and it's important for listeners to know, what is the proof of my procedure? Show me that it really is going to work to help me. Show me the data. Do you know why barbers have those red and white poles outside their shops?
So they're open?
No. Barbers used to be barber surgeons, and the red
Really?
and the white symbolize blood and tourniquets. So the white is the tourniquet that stops the blood so you can get a big vein, and then they can release the blood. They cut the vein and let the blood drip out. So barber surgeons have those poles because they were bloodletters, like the people that did in George Washington. So you can understand that even at the highest level, the father of our country who died an iatrogenic death, it can happen to anybody. And this study was very interesting. This study was in the August issue of the Mayo Clinic Proceedings. So it's new data, and it was not really publicized very much, but I think people should know about it. And what scientists did, they looked at the New England Journal of Medicine, which is probably the most prestigious journal in America, and they found 363 studies that looked at an established clinical practice. And they analyzed the results, and they found that in 146, the new procedure, the current procedure, was found to be no better or even worse than the one that was previously used.
So why do we do these new ones?
Well, let's say there's drug companies that want to patent a drug or do a procedure or maybe do things that are not so great for the patient. So 40% of the established medical practices were found to be ineffective or harmful. 38% were found to be beneficial, and 22% were found to be unknown. Can you imagine that?
It's tough to believe in 2013.
In 2013, in one of the most prestigious journals, and here we are often doing treatments that are not the best treatment for the patient. Some examples. What are examples? Well, one is hormonal treatment for postmenopausal women. And about 10 years ago, the government released a statement that postmenopausal women should curtail estrogens. And actually, since then, the incidence of ovarian cancer, for example, has been falling 2.5% a year. So it's one of the most precipitous declines in a cancer, thought to be just due to women stopping estrogens. And the same is true in breast cancer, that breast cancer rates are declining, thought because women are taking less estrogens. So it's an important point for women. There were also other kinds of studies, such as high-dose chemotherapy and stem cell transplant for breast cancer, which was found to be no better than conventional chemotherapy, and intensive glucose lowering and type 2 diabetes in intensive care actually increased mortality.
Really? Too much control was bad.
In intensive care for type 2 diabetes, that's right. And in some instances, doctors refused to give beneficial therapies despite a lack of evidence that they were harmful. So there were vaccines that were withheld from multiple sclerosis patients, thinking that they would increase flare-ups of multiple sclerosis, which was not true. Women with lupus, which is a kind of immunologic disease, were denied birth control pills for fear they increased severity of the disease. Epidural anesthesia was delayed in childbirth on the theory that it increased the rate of C-sections. And good studies showed that none of these were true.
So there's still a lot that we don't know and have to work on.
There's a lot we don't know, and there's some practices that sometimes even 10 years later, doctors don't respond to studies. So sometimes it's really great for patients to know about this information. Maybe this program will alert some patients and maybe even save a life. And one doctor, Prasad, said that procedures sound good if you talk about the mechanism. Like if you have a cholesterol clogged artery, it makes sense if you open them up. But when that was studied, it didn't improve survival. And he went on to say, people like to talk about mechanisms. They gravitate towards nuts and bolts. What does it do? How does it work? But he said the real question is, does it work?
Will it work?
Yeah, does it work? You shouldn't ask how does it work. You should ask whether it works or not. Just like the study we had before.
Good on paper.
It's good on paper. Just like the study we talked about earlier in this program about Avastin for glioblastomas. It sounds good on paper, but actually when it was given to newly diagnosed people with glioblastomas, the survival was less than optimum, less good than the usual treatment. So that's one study that points out exactly the new thing is less good than the old thing. What do you think about that?
Well, like sometimes the new thing will be better, and sometimes it'll be worse.
That's
I mean,
right.
I won't want.
So what would
I
you
wouldn't
want?
want to go back to George Washington's bloodletting, but I also wouldn't want to get Avastin, which is a new thing if I had a glioblastoma.
Right. So it's a delicate balance for patients, and sometimes it's hard for patients to know what really is the best for them. So they have to get the doctor they trust and ask and answer good questions and see the data. And sometimes it's confusing. So another point in a similar vein, actually, and it's a question that one caller after last week's program called, and he said, why didn't you talk about proton beam therapy for prostate cancer? So I said, well, if you turn to page 16 of our booklet, which I'll send you, you'll actually see the data, our data of thousands of men versus a leading center doing proton beam. Now, proton beam, do you remember what protons are from chemistry?
It's like a positively charged ball, kind of. It comes from a cell.
So it's an element positively charged. And where does it sit in the atom? Do you remember?
It's in the nucleus.
Right, in the nucleus. So you can imagine, we all remember back to 10th grade chemistry, that proton. So extracting out the proton and then focusing on the tumor and try to hit the tumor with that proton. And centers that develop proton therapy, and they're advertising a lot, so people hear about it a lot, promote proton beam. Do you know the potential advantage of proton beam?
I'm guessing it's a different kind of radiation, maybe?
Well, number one, it's a different kind of radiation. So rather than standard radiation is photon or X-rays, and the photon is like what comes out of a light bulb. Light bulbs' energy have a volt of 1 volt, so it hits the skin or hits something and bounces in our eye, and we see it as visible light. When we treat patients with cancer, it has the energy of about 10 million volts. So it goes right to the cancer. When we do it with radiosurgery, it's very focused, so we try to hit the cancer without hitting healthy tissue. So photons have been used for decades, and they're well studied, and we know them. Protons are relatively new. There's been some protons around for 60 years. Do you know, in 60 years of proton, how many studies show that protons are better than photons?
Probably not too many.
What number would you put on that?
5.
0. In the history of proton, there's never been one study that shows that protons are better than photons. Now, when you go for treatment, they say, well, protons don't have an exit dose. So the theoretical benefit of a proton is it has entrance dose. So when it enters your body, some of that body gets radiated, but it doesn't have an exit dose, unlike photons. But in this day and age of radiosurgery, we can send in the beams from many different angles so that the cancer gets the big hit from the treatment, and the healthy tissues usually, in our experience, are pretty well protected. Nothing's 100%, but even with protons, doctors don't have the experience, the decades of experience, so it's really hard to know how to focus the beam right on the cancer. But the benefit is it's a different element, and it doesn't have an exit dose. And